First, I'm going to start with urinary tract infections. This is an infection of the urinary tract. So anything that is going to be in that tract, which is going to be the bladder, the tube, and the kidney. So urinary tract is kind of an umbrella term, but it's really an infection of the urine, and then therefore wherever the urine is. So symptoms are going to be dysuria, so painful urination, hematuria, which is blood in the urine, and frequency, so the urge to go to the restroom frequently to urinate. We're going to diagnose this with a urinalysis. It's going to have positive reflection of nitrates and leukocytes. As the nurse, we're going to educate the client to practice good genital hygiene. So we're going to encourage them to wear underwear or hosiery that has a cotton crotch. Avoid any tight-fitting clothing, especially jeans. Select car seat covers that are cloth instead of vinyl. Limiting any time spent in damp exercise clothing, such as swimsuits, leotards, tights. This is going to harbor and breed bacteria and then travel up the urinary tract. Limit any exposure to bath salts or bubble baths, and avoid colored or scented toilet tissue. Avoid use of feminine hygiene deodorant sprays, and the use of condoms should be promoted. Avoid after and before each episode of intercourse, and decrease dietary sugar. They should also be encouraged to drink yeast-active milk and eat yogurt. This promotes natural flora. And do not douche. We're going to treat this with antibiotic therapy, and we're going to monitor for complications of cystitis and pyelonephritis. Cystitis is the infection of the bladder. So this is going to have very similar symptoms: dysuria, urgency, frequency, lower abdominal pain, because that's where the bladder is, or suprapubic pain, more specifically. We're going to see elevated white count and bacteria in the urine, of course, and some blood, so gross hematuria. And we're going to educate the client to make sure that they complete an entire course of antibiotic therapy. So if it's for 7 or 10 days, twice a day, 3 times a day, make sure that they're taking it as prescribed and not stopping before. They may also get phenazopyridine for urinary analgesia. So due to the painful urination, phenazidine or Azo is the brand name, but this is going to color their secretions orange. So their urine and their tears and maybe even their sweat may turn orange, and this is normal. It's not an abnormal finding. Complications of this, of having a bladder infection, is of course an ascending UTI, so it's the infection traveling up further, and pyelonephritis can result. Pyelonephritis is the renal infection, so an infection inside of the kidney. So this is going to be seen a little bit differently. This is going to be an abrupt onset of fever. Could have shaking and chills, aching in the lumbar area of the back. That's where the kidneys are. And the patient may have anorexia, so loss of appetite. They may have nausea and vomiting. One or both costovertebral angles are tender to palpation, so right there on that edge of the ribs where the kidneys are located at, when that's palpated, or even slight touch can be quite painful to these individuals due to the swelling that is occurring in the kidney. Diagnostic, we're going to diagnose this basically off of symptoms. We may do a urine specimen if we are concerned about the cause of the pyelonephritis not being from an ascending urinary tract infection. If it's due to a foreign body, then we might do a CT scan or ultrasound to rule out that obstruction, to make sure what obstruction is there, it won't be obstructing for long. So looking for kidney stone could be one of the main causes of pyelonephritis. If after 48 to 72 hours of antibiotic therapy, if they didn't do any diagnostic evaluation initially, if they're not improving in symptoms, usually you start feeling better by the second, definitely the third day of antibiotic treatment, especially that tenderness to the costovertebral angle. So if they're not improving in symptoms, then definitely we're going to do an ultrasound to make sure that any swelling, blockage, or anything that is occurring, that we can know what more directly is going on. And of course, they need to complete their entire course of antibiotics, and they're going to look for complications of septic shock, acute respiratory distress syndrome, and preterm labor. So pyelonephritis can very easily put a pregnant lady into preterm labor. And these are your special notes you want to write on your slides. So we're going to look for signs and symptoms of preterm labor, make sure that the client has education on what that looks like. So if they think they might be having contractions, even if it might be Braxton Hicks, they need to come in to be evaluated. If they're having signs and symptoms of pyelonephritis, they need to come be evaluated, just to make sure that this can be monitored at home, because this can be quite serious and detrimental to the fetus, especially depending on how preterm the infant will be. Enuresis is the intentional or involuntary passage of urine into the bed, which usually happens at night, so this is bedwetting. This is going to be in children beyond the age that voluntary bladder control should normally have been acquired. So bedwetting past 4-5 years old, when they should have that training. It's going to usually occur at night, and it's going to have to occur for this diagnosis to be in place at least twice per week for at least 3 months, and they have to be at least 5 years old. It should not be related to any other medical condition or medication that the child is on. Symptoms are going to include urgency that is immediate and accompanied by acute discomfort, restlessness, and then urinary frequency. Testing, we're going to diagnose this by different factors, of course, symptoms, but we're going to consider and look down the reason, the causative factor. So it could be an organic issue or a psychological issue. So you have to go down both avenues and make sure that you're treating it correctly. So if there's this psychological issue or trauma that is going on, and this is a form of regression versus a pathological problem with the child. Nursing interventions, we're going to restrict or eliminate fluids after their evening meal, so after dinner time. No caffeine or sugar beverages after 4. We're going to purposely wake up the child in the middle of the night to go void, so emptying their bladder frequently. Motivational therapy. You're not going to scold the child or shame or threaten. You don't want this to be a negative experience and put even more psychological factors on there. So no scolding. You're going to make sure that communication is directed towards eliminating the behavior. I'm writing here, no scolding. Oops, that's a big D. Eliminating the emotional impact of the problem and building self-confidence of the behavior. So treatments could include tricyclic antidepressants. They have an anticholinergic action on the bladder, so that might be one way of treatment. They also could do antidiuretics to decrease urine output, especially right at nighttime, or antispasmodics. Another one that's very popular is desmopressin acetate, other known as DDAVP. So this is seen as a nasal spray. It reduces nighttime urinary output to volume less than the bladder capacity. So if the bladder only holds 300 milliliters, then this is going to decrease urine output to less than 300 during these hours of sleep. Complications of this condition, not the medications, but of the condition, of course, is going to be skin breakdown. So if this child is laying in pee all night long, does not wake up, or emotionally doesn't want to wake up the parents, they could still be wet all night long and get very bad skin breakdown, diaper dermatitis, things like that. Of course, family stress is going to be a condition that is going to have to be managed mindfully, and then medication side effects that may be occurring. Phimosis is when the foreskin of the penis is not retractable, so it cannot be pulled back. This is usually due to constraint of the skin around the tip of the penis, and usually will require surgery. A hydrocele is the buildup of the fluid around the testes. So this is in this area, this is what it's pointing to. All of this area fills up with fluid. This will require surgery. Cryptorchidism is the failure of a testicle to descend. So you'll see here this is stuck in the inguinal area. So it may stray off or stop above the groin and fail to descend into the sac. This will require surgery as well. Hypospadias is an abnormal opening of the urethra found on the underside of the penis. Now, they could actually have the opening here and opening here. So you could have multiple openings. This one, of course, would be normal. And this one would be hypospadias, so hypo being under. So any of these areas are going to be those possible sites. This is going to be, of course, on your initial assessment when the child is born, that you're going to look for this, as well as watching the infant urinate. So it may be just slightly hypo, and under first examination it would be normal looking, but once they urinate, if it skews off instead of going straight up, then you know that there's hypospadias. So this is abnormal and will require surgery to fix it. They're going to be more prone to urinary tract infections if it is not surgically fixed. So extravia of the bladder is when the bladder forms not inside of the abdomen but through the wall that's supposed to hold all of the contents of the abdomen in. So it forms slightly outside of the body. So then this, of course, will need to be surgically replaced. A skin flap may need to be involved. Exogenous genitalia is the development of genitalia that is not specific to just the male or just the female. So this diagram shows how with hormones and development, how the male becomes the male and the female becomes the female. But you see at this point, they are quite similar, and only due to development and hormones is it going to separate at this stage. So if development is stopped here, or hormones or any other issue that was involved with development may have stopped this here. And so then your genitalia is not just one. It could be both. It could be an external opening that seems female, but internally no other female organs, or vice versa. A testicular torsion is the twisting of the spermatic cord, so it twists around, coils up. This is a medical emergency, quite painful, and will lead to death of the testes if it is not surgically corrected. Nephrotic syndrome. Nephrotic syndrome is the increased glomerular permeability of plasma protein, resulting in massive urinary protein loss. So let me get a color here. So this is your normal here. So these little blue dots are your protein. You're supposed to filter and you get rid of your waste, but then your protein is supposed to stay in your blood. It's not supposed to be filtered out. What happens in nephrotic syndrome is that there's an issue with the glomeruli, the filter of the kidney, is filtering out the protein. So then you get protein in your urine. What's going to happen is that protein not being in your blood level, your plasma levels, is going to cause most of your symptoms. So that's going to have your edema, your weight gain, puffiness in the face and the eyes. You're going to have abnormal swelling pretty much everywhere. So swelling in the abdomen, you have ascites. On the lungs, you have pleural effusion. You have labial, scrotal swelling. You have ankle, feet edema, edema of the intestines. And so that's going to cause diarrhea, anorexia, poor intestinal absorption. Client's going to be irritable, fatigued, lethargic. They're going to have blood pressure that's normal or slightly decreased, and susceptibility to infections. They're going to have a decreased urine volume output, so that's called oliguria, and the urine may be frothy as well. Diagnostically, we're going to see that, of course, there's protein in the urine, so proteinuria, low albumin, and high lipids in, this is serum, blood testing, and then high cholesterol. They're going to have a high GFR. And as the nurse, you are going to reduce any excretion of urinary protein as much as possible by reducing fluid retention in tissues and preventing infection, minimizing complications related to those therapies. So that's going to involve a dietary restriction of a low salt diet and fluid restriction. Low salt and low fluid. So fluid restrictions. Oh goodness. That's supposed to say fluid. So we're going to treat this with diuretics. So we're just going to try and get off all of the excess fluid that is here. So because this is so diluted in the sense of protein, there's hardly any protein here. If we get this excess fluid off, it's going to be also equalizing your protein serum levels. And we're going to probably need to give albumin. So that's a protein that's going to help maintain fluid in the circulatory system, so it'll go hopefully back to normal. And then antibiotics and corticosteroids. We're going to look for complications for infection, circulatory insufficiency related to hypovolemia, and thromboembolism. So hypovolemia could occur because we're trying to pull all this fluid off of them, low salt, so nothing is staying in them. So if we pull off too much, okay. And then thromboembolism because of the dehydrated state that could occur from what we're doing. Acute glomerulonephritis. So it's similar to the nephrotic syndrome. It usually is caused due to a streptococcal infection, a mild cold, or could have been that there was no previous actual infection, but it's usually related to recent infection. So strep is usually recent. That was horrible. Strep. So this causes the immune complex response and causes the glomeruli to become edematous. So this all swells up and causes infiltration of the leukocytes, including the capillary lumen. So you're going to see oliguria again. So very little output. That was bad. And then you're going to see edema, hypertension. So remember, in the other one was normal to low. This one is going to actually be high blood pressure now. Circulatory congestion, edema, especially periorbital edema. Anorexia, pallor, irritability, lethargy, ill appearance, seldomly expresses complaints just because they just don't feel good. They could have a possible headache, abdominal discomfort, dysuria, or vomiting. Diagnostically, we can test for this with a UA. It's going to show hematuria and proteinuria, of course. They're going to have an elevated BUN, so this is like actually affecting stuff, right? BUN and creatinine are both going to be elevated, so make sure you know your levels. And then again, dietary education. So having that low salt, low weight restrictions, fluid restrictions. We're going to make sure that we do daily weights. Daily weights is going to be our best indicator of fluid retention. So daily weights is going to be how we're measuring that. They're going to need education on follow-up, frequently follow-ups, making sure that they return for their follow-ups. They're going to actually be coming back weekly and then monthly for evaluation of their urine, just to make sure that this is improving. So we have that sodium and water restriction. And then when they're having a period of oliguria, that's when we're going to have them restrict their potassium. But not always. They're not always going to need a potassium low diet. But if they're not putting out urine, they're oliguric, then we need to institute a low potassium. Okay. Only if it's oliguric. So make sure you understand how much output oliguria means. And then we're going to look for complications of the glomerulonephritis, which what we're going to see is chronically is that they're going to have an abnormal urinalysis. Maybe a few protein is being slipped out, but they don't have an active infection that's going on right now. But because of that, their chronic renal function may decline and may lead to end-stage renal disease. So they're probably going to end up in kidney failure. Hemolytic uremic syndrome is usually due to an E. coli infection, and it leads to kidney failure and then dialysis. It's mainly supportive. You can't really treat it with antibiotics, and you're just going to need plasmapheresis to try and rid and filter out as much E. coli and as much of this toxin out of the bloodstream as possible. But damage to that kidney is going to be irreparable, and so they will end up in kidney failure. What we're going to see in these clients is thrombocytopenia and hemolytic anemia. So they're going to have the cells that are going to be breaking up, so hemolysis anemia, so their red blood cells are broken, and then thrombocytopenia, so their platelets, and then their renal insufficiency, so they're going to end up in renal failure. Acute kidney injury or kidney failure is the sudden ability to regulate volume and composition of urine appropriately in response to food and fluid intake. So what that means is, based on what you're intaking, you're not able to output correctly. You're not filtering correctly, but it's a sudden onset, and it's usually reversible and over a short period of time. But in pediatrics, this increases their mortality. So it's actually really bad for a child to get it. Or that's an A, mortality. It's usually reversible, but because of the high mortality in pediatrics, we're going to treat this very closely. It's related to glomerulonephritis, obstructive uropathy, or exposure to nephrotoxic chemicals. Like I mentioned before, nephrotoxic chemicals. It could be an antibiotic that they've been on long term that's nephrotoxic, or it could have been that E. coli with the hemolytic uremic that ends up coming to chronic kidney failure, which I'll talk about next. So symptoms of acute is going to be oliguria, associated with azotemia, oliguria, metabolic acidosis. So make sure you know what these terms are, you know how to identify these. So what does it mean to be oliguric? Like number-wise, milliliters. And then metabolic acidosis, how to determine that. And then, of course, electrolyte imbalances are going to occur because you are not filtering. Diuresis then happens after the oliguria, and then return to normal volume output occurs. So it's like a 3-step process. But during that time, the client can have nausea, vomiting, drowsiness, edema, hypertension again, and edema. They're going to have an elevated BUN and creatinine. So know what those levels are. We are going to monitor their rehydration therapy very closely. We're going to have strict I's and O's, and we're going to try and prevent complications as possible. So you're going to be calculating intake and output very closely, and we're going to restore their volume for dehydration. So our goal is to improve their urine output. So the absence of oliguria. So we want to get rid of the oliguric stage so that they can move to the diuresis stage, right? So we might need to monitor their strict I's and O's with a Foley catheter. And we're going to make sure that their input and output are balanced. So that's how we're monitoring, why we're monitoring our I's and O's, right? We want this to equalize. So making sure that the fluid is being retained. So you should have a balance there. When it becomes greater output than input, it might be okay for a while. Hopefully we're in that next stage of diuresis, but we still need to monitor it. But our goal is at least balanced and then get to the diuresis. We're going to monitor this BUN and creatinine during therapy. This is going to be key. So then our goal would be then to have a normal BUN and creatinine. So again, knowing your levels there. Complications are going to be water intoxication and hyponatremia because we're rehydrating them. So then we've overhydrated them, and remember, their kidneys aren't functioning that great. They're not filtering. So then we're throwing a bunch of water in them, and they can't filter it. So then they retain it, and they get water intoxication. So this needs to be monitored very closely through your strict I's and O's, your Foley, and your input-output calculations. We're going to watch for that hypertension, make sure it doesn't lead to any seizures, cardiac failure and things, okay? Chronic kidney failure is the progressive deterioration over months to years. So this isn't acute because it takes a long time. It takes months to years. So there might be mild intermittent symptoms that can come, can go, not really be true, really horrible symptoms like the edema and all of a sudden the acute phase. So this is slowly happening over time. So then, especially in children, it may not initially be reported because they just feel ill one day and then they're perfectly fine the next day. So then the client or parent may not report it to the provider until later, and now we've gotten severe damage to the kidneys. So labs are going to show, again, the metabolic acidosis. So make sure you know how to figure that out. Elevated BUN and creatinine. That was horrible. Let me start that over. Elevated BUN and creatinine. And hyperkalemia. So now we actually have a potassium issue now. Anemia, hypernatremia, and hypocal. So as the nurse, we're going to do daily weights again. Very key. This is going to be our most accurate way of measuring fluid retention. Daily weights. I think it's like 1 kilo of weight change is equal to I don't even remember. It's so many milliliters. But you won't need to know that to calculate weight for how much water retention, but there is a calculation. But you will take the weights very seriously. So if you see even like a 0.5 kilo increase on someone's daily weight, you're concerned. They should not be retaining and have that much of a fluctuation from day to day, because there might be some fluid retention here and you need to investigate sources. So this is bad. Treatment, we're going to treat with Epoetin, however different people say it, E-T-I-N, Epoetin alpha. So this is going to increase the production of red blood cells and then help with kidney function. But if you take Epoetin alpha, you need to increase your iron intake, of course, because you're talking about red blood cells here. So you need to increase your iron intake when you take Epoetin. They also should monitor their fluid intake. So they might be on fluid restrictions. So monitoring their fluids. Complications are going to be infections, because with just like with the glomerulonephritis, when you have issues going on with the filtration here, the inflammation that is going on, you're going to increase your chances of, or not chances, but infection risk increases. So we're going to look for signs of pneumonia, signs of UTIs, and septicemia especially, so sepsis. Pulmonary overload, so if the fluid gets all built up and their BUN and creatinine is high, they're retaining fluid, the fluid could press on to the lungs, and therefore we have pulmonary overload. We could also have CNS symptoms because of all of these electrolyte issues going on right here. Hypertension is going to be a complication that is going to be a late sign for chronic, whereas we saw it as a symptom of an acute. So this is a late sign. This is bad. And then cardiac failure due to, again, the electrolyte issue. Dialysis, we're going to probably see this due to kidney failure. And this is because we need a rapid correction of fluid and electrolyte abnormalities. There's different types. There's the peritoneal dialysis, this one here on the left side. So this is a peritoneal catheter that is inserted into the area, the peritoneum. And so this fluid is building up in the peritoneum, and then it is accessed with a catheter, and this dialysate fluid is going in, and the barrier between the peritoneum and the body is going to exchange, and then you're going to get your wastes off, and then it will be drained into another bag, your wastes. So the amount that goes in should also be the amount that comes out, so that there's no retention, right? So same thing with hemodialysis. So hemodialysis is doing the filtration but through the blood, and so not the peritoneum. So hemodialysis is we're going to either have a fistula, a graft, or an external vascular device. So vascular device could be a perm cath, so they point up. It could be a Quinton catheter, and they point down. So these ones are not tunneled, whereas the permacaths are tunneled catheters underneath the skin. So these ones are less likely to cause infection. These are temporary. This is until they can have surgery, usually on their upper arm. They can do it in their lower arm. And so then they will either create the vein and the artery to come together. Trying to create red and blue together. So then there's this area that's purple. So then it's accessed and then filtered out. So there's the arterial and the venous there. So it's either done by fistula, so they create a hole between the two and surgically create that fistula, or they graft it together by a vein in like their leg or something that they put here, and then like graft the vein and the artery together. So you don't even know all the details except for it's to filter out. So again, it goes in, it filters out, and then it comes back out. So the dialysate, the fluid that goes in, the amount that goes in should be at least what comes out, so that there's no fluid retention. Now, if the client is having fluid retention though already, so they were already retaining fluid, we then of course would want the fluid to be more that comes out, right, than what goes in, and that way we're pulling fluid off of this patient. However, when we pull fluid off the patient, we could have a lot of cardiac issues because a lot of the fluid shift and then the electrolyte shift. Fluid and electrolyte, because it happens so quickly. Even though it's over a couple hours, it's still quite a quick time for your body. We're also going to observe the dialysate, the fluid, to make sure it's clear when it is coming out of the peritoneal cavity. It should be clear. If it's cloudy, then it could be a reason for infection. It may be harder to see cloudiness on the machine for dialysis, for hemodialysis, because it's blood, but you can look at it closely and see some infection sometimes there. And of course, that cloudiness, that infection should be immediately reported to the provider. The child may need education about their site, if it's peritoneal site, or their catheter or fistula, just to know what it is. It's to replace their filtration of their kidneys, and at the meantime, until either their kidney can kick back in after maybe a acute kidney injury, if it comes back and starts working again, it's to give their kidneys a break, however you want to say it to the child. But because it is several hours long of a procedure, distraction activities that are developmentally appropriate may be something to be mindful of. Of course, complications are going to be that infection, also hemorrhage. So the access catheter puncture wound, or when it's removed, if it continues to seep and weep and doesn't stop, because that is an artery that is there. So if the artery keeps seeping, you could have arterial bleeding and hemorrhage. And then again, that rapid electrolyte fluid change here. So if they are exhibiting any cramping or hypotension, that could be a sign that this rapid electrolyte shift and fluid shift has occurred, and maybe it is, not maybe, but it is an emergency situation, and you should notify the physician.